In this module, we've been talking about the different control knobs and how we can tweak them or adjust them to improve the performance of your health system. In this session, I'll be talking about the organizational control knob. As you go through the sessions in this module, and as you do your assignments, especially on the diagnostic tree, you'll realize that a lot of the challenges that we have in our health system that are preventing us from reaching the ultimate health objectives, a lot of those challenges could be addressed by changes within the organization. So the organizational control knob then becomes a mechanism for which we can look at improving the performance of the health system. So let's get into that in more detail. So if we look at the organizational control knob, we're going to be looking at it from the perspective of two different levels. The macro level, which is the much more bigger picture, broader perspective, and then the micro level. So when we talk about the macro level, we're talking about who does what. What are the different delivery organizations that we have in our health system? What are their functions and who should do what? We will also talk a little bit about the different interactions amongst these organizations. Who is responsible again for what function in terms of buying or selling products or services? And what are some of the incentives that these interactions can create? And how could we use all of these different areas to change the performance of your health system? At a micro level, we're looking specifically at the internal structure of the delivery organization. What is its management and leadership situation? Could we utilize that to leverage and improve the performance of that organization to help us achieve the ultimate health objectives? So these are the two different approaches that we're going to be looking at from a macro level as well as from a micro level. So the organization is very important. I think all of us understand that very clearly. Cost, quality, and access depend on how the organization functions at a macro and micro level. But certain economists, they just focus on incentives and they don't necessarily understand that we need to look at the organization from the macro and micro level perspective as well. And so if an organization has to do better, firstly, it has to have a reason to change its behavior. And secondly, it must have the capacity to change. So when we think about tweaking and changing the organizational control knob to improve the performance of the health system, we need to think about, firstly, if that organization understands why it needs to change, and if that is sufficiently enough for it to change its behavior. And secondly, does that organization have the capacity to change in terms of having managers and leaders who understand what needs to happen, as well as the health workers within that organization understanding what needs to happen in terms of their capacity and their skills? Now, we do know that if we look at who does what and we need to change who does what, it's likely to be very controversial, especially at a political level. And we know that any organizational change is going to depend on what impact it's going to have on the frontline workers and their managers, because they are the implementers. Managers and frontline workers are the implementers. If they don't understand the change that needs to happen, if they don't have the capacity to make that change is not going to happen. We often see that when change is predicted or presumed, there's anxiety within a micro level organization. And that can impose costs because employees can resist the change that needs to happen. So we need to be cognizant of these particular issues as well when we're thinking about tweaking that organizational control knob. What are going to be the politically imperative controversies? How are we going to make sure managers and frontline workers can implement? And how do we manage change? So what is our change management strategy to address anxiety issues amongst health workers from the micro level internal organization's perspective? So if we're going to adjust the organizational control knob, if we're going to tweak it to improve the performance of your health system, we're going to be looking at 3 strategies. The first thing is we need to change who does what. Secondly, we need to change the incentives and the constraints or barriers that are hindering organizations or that can enable organizations to actually effect change. And this could be through changes that are affecting their external environment. We should also look at changing the internal environment, as I mentioned earlier, at the micro level in terms of the skills of managers and health workers in organizations. So we'll be going into all of these 3 areas in a little bit more detail in this presentation. So in terms of who does what, we're going to talk a little bit about the role of public organizations or the role of private organizations, because for us in South Africa, that's the big debate. We're going to talk a little bit about how we're going to reorganize health services and the delivery of health services. Should we centralize or should we give more localized control in terms of decentralization? What's the function of ministries and other regulatory agency going to be in this change that we're presuming? What about our hospitals, our clinics, and even the community? What are their roles and functions going to be? And can we explore task shifting among providers? When we look at changes within the external environment for organizations, we're looking at external incentives and conditions. Can market forces or a lack of market forces affect how public and private organizations functions? What are market failures, especially in the health sector, and how do they affect the performance of your organization? And what are government failures in health, and how do they affect organizational performance? So we'll get into a little bit more detail on this in the coming slides. And then in terms of internal incentives and conditions, how can we ensure our managers can actually manage and lead? And what sort of incentives can we bring into an organization to improve this? What about the role of organizational culture? Does it improve the performance of an organization? And do we have management tools that we can use to improve the performance, especially of our public organizations? So again, as I said, we'll be discussing in a little bit more detail some of these areas in the slides to follow. So let's start with the first thing of who does what. Now in South Africa, as I mentioned before, we have this dual health service delivery model where you have a public health sector that's catering largely to the medically uninsured, and you have a private health sector that's catering mainly to those who are medically insured, but is a much smaller proportion of the general population. So the major debate here is, what should the role of markets be in the healthcare sector? Should we leave the healthcare service delivery to the whims of the general market? Or do we want government to be involved in the healthcare market? When I'm talking about a market, I'm talking about your general economic market where you have goods and services, and you have prices for those goods and services, and you have buyers who want to purchase those goods and services, and you have sellers who are providing those goods and services at a certain price. So that's the market that we're referring to, the healthcare market. So within this healthcare market, what should the role of the private sector be? What should the role of the public sector and specifically the government be? That's the debate. And then we're also going to talk about when are such markets good? And why would they fail? What circumstances would cause them to fail? We'll also talk a little bit about what governments are good at in terms of this role, and also what would cause governments to fail within this concept as well. So let's first use the argument of saying, if we're going to decide who does what, and one of the arguments is saying, let's use the private sector to provide health care. And there's a very strong argument for that that's currently playing out in our media for the last few years, especially as we're talking about the national health insurance. There's a lot of dissent amongst the private sector providers and a whole lot of other external stakeholders, because they believe the private sector is best positioned to provide healthcare for the country. So let's look at the arguments that are being made to justify the use of the private sector. One of the arguments is that the private sector is very competitive. And in terms of your normal economic market, we know that competitive markets can force sellers to be efficient, and they can produce services and costs at a minimum cost. So that's the first principle, okay? We also know that if in that situation you have a competitive market, those sellers that are in that market are going to respond to what the customers need. And they will produce what and only what the customers are willing to pay for. So it becomes a demand-induced market where the customers are saying, this is what we want, and other sellers willing to produce that and give it to us because we are willing to pay this amount for this particular product. So there's a demand-induced market from the customers. That's the second argument. The third argument is saying that if you have such a competitive market, you're going to foster innovation because decisions will be decentralized to where the customers are and what the customers want, and it's going to be more locally contextual. And the sellers will have strong incentives to adapt to new technology because they're responding to the demand by customers. And therefore, they're going to be innovative in terms of the products and services that they will produce. That's the third argument that's supporting the use of the private sector to provide healthcare. The fourth argument is that if you have such a competitive market, you can avoid corruption and the unresponsiveness of large government healthcare bureaucracies. If you have a private sector that is free of red tape and all the rigid rules that government has, they're more likely to be responsive to what the customers want. And they're more likely to produce products and services that the customers want. And again, it's based on a demand-based market. So these are the four big arguments for using the private sector to provide healthcare in any country, especially in South Africa. Now, I want you to think about each of these points carefully. And for better context, I would strongly encourage you to go and read the 2019 Health Market Inquiry Report, where the Competition Commissioner established a task team, to actually look at private health sector practices in South Africa. So go and read that report and then come back and look at these 4 main arguments in this particular slide. Okay? But anyway, let's leave this for now. In this case, in all of these slides, I must just highlight that Prof. Tom Bossert, who developed the content for these slides, is not talking from the perspective of South Africa. He's talking from the global perspective. So all of these comments that I've got here, all of these points that I've got in all these slides are referring to the global experiences. But I want you to think about it and reflect about it from our South African perspective too. Okay, so go and read that South African Health Market Inquiry Report and also think about these points. So these are the arguments for using the private sector to provide healthcare. Now, one of the fundamental theories around competitive markets, there's an economic theory of competitive markets, is that it allows individual tastes and preferences to determine what they get. So there's freedom of choice. So as I mentioned previously, if there's a demand-induced market where the customers are able to say, this is what we want, this is what our preference is, and this is what we are able to pay for, you're stating that there's freedom of choice. Your customers, and in this case, let's use the example of our patients and our clients, they know what they want. They have certain preferences and they can then determine what they get. So that's a basis, a fundamental principle of the economic theory around competitive markets. Secondly, these individuals, these customers, are able to shop around for the best deal. So remember, sellers will understand what households and individuals want, and they're going to make sure they're going to try and provide what they need at the lowest possible cost. So customers can go around and shop around for the best deal. And in this case, because they're shopping around, there's competition, and that competition encourages efficiency and innovation and quality. So this is the basis of the economic theory around competitive markets. So let me give you an example that I think many of us may resonate with. Say you as an individual want to buy a television set for your household. Obviously, as an individual or a family, you're going to talk about, oh, what do we want in a TV set? What do we want in a television set? So the children, your spouse, yourself, you're going to say, no, it needs to be 40-inch. It needs to be flat screen. It needs to be, X, Y, and Z. You have your own individual tastes and preferences. It needs to be this particular brand. We're looking for Samsung or LG or whatever is the brand that you're looking for. And as you're having those discussions, in your mind, you know that you have the freedom of choice to determine what type of television set that you can purchase. So that's an important principle that drives your decision making. You also know that you can go around, you can go to Dion Wide, you can go to Macro, you can go to Game, you can go to any store, Samsung stores, and shop around. Incredible connection. Go and shop around for the best deal. And again, knowing that you can go around looking for the best deal empowers you as an individual. Okay? And again, it's going to inform your decision making. And because you're going to these different stores, each of these different stores is going to come up with, competition. They're going to say, we've got this special happening here, an incredible connection. If you buy a TV with us, you're going to get this particular product free as well. Or we're actually selling the top-notch top-notch brands at a discounted rate, or this particular TV has got this innovation. So because customers are going to be demanding what they want and what they're willing to pay for, there's competition in terms of making sure the product is the best, the product has the best quality, the product is the most innovative, and it's at the most cost-effective price. So that's the basis of economic theory. So think of this example of an individual purchasing a television set, okay? And you can see how all of these economic theories apply. But unfortunately, you can't really apply the same principles in the healthcare market. And we'll come to that now. Currently, economists and the supporters of saying the private health sector is the best placed to provide healthcare, they're thinking of this economic theory of competitive markets. But you can't equate a television set to a healthcare product or service. Okay, but we'll come to that right now. We'll show that how it doesn't make sense. So, therefore, in order for there to be a very good competitive market, there has to be certain conditions in place. Again, we're using the example of that television set. If you are the buyer, you are the client, you are informed because now you've gone and done your research in terms of understanding which television sets are the best. You've discussed with your family, how much are we able to spend? We're rational, we can spend this amount, so let's go for this type of television set. You have the time, you're taking the time to go around and see. I'm sure those of you who've purchased television sets know how much time your husband or your father or yourself you take to go and shop around. You go around weekend after weekend checking what different brands are out there and what are the different specs, and you go to different shops, right? And you're also thinking about, what am I able to afford, and what am I willing to pay for this television set, right? So these are principles and conditions that need to be in place in order for the buyer and the client to be able to engage within this competitive market. Now let's look at the seller's perspective. From the seller's perspective, or the producer of the product, it's implicit that there has to be many sellers. We know there's Samsung, there's LG, there's Hisense, there's a whole range of other producers of television sets. There are sellers of those television sets. You've got Macro, Incredible Connection, Dion Wide, you've got Game, you've got Samsung stores, you've got all sorts of stores that are selling these products. And each of these sellers can enter and exit the market freely. There's no restriction per se on them. There's no criteria or accreditation requirement for them to enter or exit the market. All right. And then the demand is not based on supply. The demand here in this case is based on the customer. So it's not a supply, it's not the seller or the producer who's creating the demand, it's the customer, because the customer wants that television set. Okay. So there's little supplier induced demand in competitive markets. Thirdly, if you look at the actual product or the service, so in this case, the television set, it has to be homogeneous across the different sellers. In other words, whether you go to Incredible Connection or you go to Game, or whether you go to Macro and you're looking for a Samsung television set, you know that it's going to be exactly or very similar in terms of inputs and quality. It's going to be the exact same product. Secondly, you know the price in advance. When you go there, you can immediately see. You don't have to negotiate. The price is already there on the item, that this is the price for this television set. So you are then able to make a decision as a client whether or not you can afford to pay for it. Okay, so those are the principles again, or the conditions that need to be in place for competitive markets to exist from an economic theory perspective. So I've used again the television set as an example of a product here. But again, I want you to think about it from the perspective of the health sector. Let's now go to that. So again, all of these arguments and all these conditions are from the perspective of, if we have a good competitive market and we have buyers and sellers and products, why then can't the private health sector provide healthcare on behalf of everybody? But these sort of markets fail. Specifically, the health market will fail. And why? Why would it fail? Because firstly, And let's look at it from the perspective now, not as a television set, but let's look at a health product, a health service. So whether somebody wants to have a normal delivery, they have a pregnant woman and she wants a normal delivery. She wants to deliver her baby safely. There's consumer ignorance in terms of what is expected. Many of our clients, our patients, don't know what to expect when a woman falls pregnant. In their mind, they're just thinking pregnancy equates a baby born. They don't know what happens in between. There's a lot of ignorance and understanding in terms of what is expected. Okay, so the customer in this case is not informed and is potentially not necessarily rational, because they're worried, they're anxious, they're excited. There's a lot of emotions that are going through their mind. So it's very difficult to be rational when you're worried or concerned or super excited. There are limits on shopping around. You know, as far as you know, you're living in a rural, very vulnerable area. Maybe there's only one clinic over there or one private hospital around there. That's the only place where you can go and access care. So it's not like you can go to multiple sellers of antenatal care or labor care in that particular area. So there are limits to how much shopping around you can do. Thirdly, your ability to pay is constrained. You don't know, firstly, what's the cost of going to deliver this baby? What's the cost of getting antenatal care? Nobody's upfront about it. And even if they were, it could be a cost that's much higher than you're willing to pay. And because you can't shop around, you're stuck with that cost. Then we have the agency problem. Because if we look at healthcare, the decisions around healthcare are not taken by the client or the consumer like they would make a decision on buying a television set. The decision on the type of healthcare service or product that they're going to need is going to be made by a separate person. A principal, an agent, in this case a health service provider, is going to make a decision on their behalf. And that can create a problem because there could be a conflict in terms of what the principal wants to do as opposed to what the client wants. So let's use again the example of pregnancy. You know, the client just wants to have a safe pregnancy and they want to deliver a healthy baby and they're thinking of having a normal delivery. But they go and see an obstetrician and the obstetrician suddenly says, "Oh, you need a cesarean section." And the client has no idea whether a cesarean section is really needed or not because they don't have enough information to make that decision. The doctor is potentially pushing the cesarean section because it may be easier for them. They don't have to wake up in the middle of the night to do a normal delivery. And of course, there's a higher cost associated with the cesarean section, and so they're able to generate more money. So suddenly you can see that there's an agency problem here. The client is not informed. The client is not able to make a decision based on knowledge. The decision lies with a third party or another party, in this case, the provider. So that agency problem also creates a challenge in this health market. The issues around limited competition is the same thing as shopping around. If there are very few people providing that care, that healthcare service or product, they're able to then determine the price. And they don't have to be innovative. They don't have to ensure about quality because they're the only people providing that service. So there's some sort of monopoly in terms of providing those services. So competition is not necessarily being encouraged. There could be overconsumption and advertising. So in this case, it's becoming more of a supplier-induced market rather than a customer or demand-induced market. The suppliers are saying, we need to do more cesarean sections. We need to do more of these activities or these services. And they're advertising it in such a manner that the customer really doesn't understand whether or not it's necessary or not. There are also external effects. If we don't consider those external effects, that can also create market failure. And external effects can be, positive externalities or even negative externalities. And these are things like, your negative externalities are costs that can be imposed on others. Opportunity costs that can arise, while positive externalities are things like vaccinations and other interventions that can benefit others, right? So these external effects can cause your market prices to deviate from the true social cost and benefits, leading to market inefficiencies. Okay, so again, an example of a negative externality is, for example, when there's a pollution from a factory that harms the health of nearby residents, right? And in such cases, the market is overproducing that particular goods or service because the producer is not bearing the full social cost of pollution, all right? So that's an example of a negative externality. But anyway, I'm just giving you examples of why markets tend to fail if we don't consider external effects. So what happens when markets fail? When the markets fail, and in this case, again, let's look at the example of South Africa, where you have the private health sector and the public health sector. So if we're talking about the argument of saying, let the private sector provide healthcare for everybody, we know that what's going to happen is the market is going to fail, as we've just highlighted, and that's going to result in unequal access for the poor, because the poor can't afford to pay for healthcare. They have limited options. They don't have enough information, and they don't have much choice in terms of understanding what needs to happen. Okay, and this can result in inefficiencies because you end up paying too much for services that are monopolized. So that's your technical inefficiencies. So remember when I was speaking about the intermediate health objectives and I spoke about technical inefficiencies. If you are allocating a particular resource to a particular service, but you're spending too much on it, it becomes a technical inefficiency. If you're also paying too much for the wrong service, in other words, you've allocated it to the wrong service because of supplier-induced demand, then that becomes an allocative inefficiency. You decide to pay for cesarean sections because the supplier is saying that's what I will provide, but maybe that's not what is needed. Then that becomes an allocative inefficiency. Okay, so the consequences of market failures are that you can have several inefficiencies in the system. It can also result in poor quality because monopolies there's no competition, they don't have to worry about demand, so they are not going to worry about quality. And even if they're more worried about high cost, and the high cost does not necessarily mean appropriate quality. So again, these are the consequences of market failure. And I would urge you again to go back and think about these from the perspective of that health market inquiry report that I mentioned earlier. Now, how can governments overcome such market failures? One of the mechanisms could be that governments would provide and finance services directly to improve access. They could subsidize insurance for the poor and low-income households to improve financial protection. They could fund training and research to find out what's the most cost-effective intervention or strategy or product or service that needs to be provided. They can regulate the private sector to improve competition. And they could provide information to overcome this information asymmetry. Remember the agency problem? That you have the principal and the agent, and there's information asymmetry between them. The client doesn't know enough about their particular health condition to decide what needs to be done for them. But we can, as government, provide information to clients so that they are aware that if you are pregnant, you need to access early antenatal care. And if you access early antenatal care, you're able to have a safe pregnancy. And if you can manage the risks in those pregnancy, you could potentially have a normal delivery. But if you were to have a cesarean section, these would be the reasons why you would have a cesarean section. So when your doctor says, I'm going to do a cesarean section, you need to be able to say, oh, is it because of this reason? So these are mechanisms that governments can introduce to overcome market failures. Think about it now from the perspective of the National Health Insurance. Okay, so now we're moving towards whether or not a government has a role to play in terms of addressing these market failures and getting our health system to perform in a certain way. So now let's come to the second argument. So in the first argument, we were saying who does what? Can the private sector provide health care? And we've just shown that in that particular context, the health market is failing in South Africa. And so the argument for the private sector alone to provide health care does not hold much weight. Now let's look at the second argument, that government alone should provide health care. And these are the arguments that support why governments should. Okay. Firstly, we're saying, and again, these are global opinions, as I've mentioned before, but I want you to think about it from the perspective of South Africa too. So governments are really good on acting on expert opinion. And they would respond to needs rather than wants. So they're going to say, what does the population need as opposed to what the population wants? And then they can act on that in terms of expert opinion. Governments can think about providing services equitably based on need and vulnerability. So especially to the poor who can't afford to pay market prices, governments can provide those services where there's the greatest need and vulnerability. And government decisions potentially are made in ways that are fair, transparent, and accountable. I mean, that's the whole point of our democracy, is that we as citizens are voting, and we're voting in a government that we believe is going to be fair and transparent and accountable and is going to put our needs first. Okay, so these are all the arguments for government provision. But, and again, we know this, especially from the context of South Africa, we know that there is also government failure. And why? Why are governments failing? And again, reflect back in terms of understanding what's happening in South Africa. Political influence is not neutral. Much as we are electing a democratic government, the interests of some actors is greater than public interests. So the actors that we're electing, the politicians that we're electing, may not necessarily be thinking about our needs, but rather about their wants. And those could be the wants of that political group or the wants of that individual politician that has been elected. Secondly, there's definitely patronage and corruption versus merit, and we see that a lot in South Africa. I mean, these are the arguments against the government providing healthcare in South Africa that the private sector brings up. Okay, that there's patronage and there's corruption. And that we know that the interest of politicians is in being re-elected so that they can have more power and more control rather than in them actually providing good health care. So governments fail because political influence is not neutral. That's one reason. Another reason that governments fail is because public bureaucracies are inherently inefficient. We've just said that governments are massive and large and huge. And therefore, and again, this is from a global perspective, but I'm sure a lot of these points resonate with us in South Africa. When you have large government bureaucracies, they don't always have sufficient information and technical knowledge or capacity to make good choices. They may function in silos, which we see happening. They may have very rigid rules and regulations which are difficult to change, and they may not necessarily have all the resources, including financing, to actually become more efficient. So public bureaucracies inherently are inefficient, and that results in government failures. So how can you overcome these two big government failures, the political inefficiencies as well as the bureaucracy inefficiencies? Firstly, you want to think about how can we reduce corruption. And one way could be to make things more transparent. You want to have more clear rules in terms of what needs to happen. You want to have better accountability and governance, right? You also want to have more merit-based human resource for health management to replace patronage. You want to ensure that there's competition for public funds between public and private providers. You don't want public entities to feel that they can do anything because there are no consequences. There must be some element of competition as an incentive to get the public organizations to function better. You can also decentralize and shift some of that power and control to more localized entities such as local governments. You can create more autonomy for hospital managers. So instead of having politicians centralize control and power at a higher level, you can move and shift some of those responsibilities much lower and closer to the people, where there's going to be greater understanding of what needs are in those communities. You can also use private sector management techniques such as re-engineering of government, re-looking at government processes and how to make them much more efficient. We know about techniques such as lean management and so on. So these are different sort of examples of how you can overcome government bureaucracy inefficiencies as well as issues around political interference. But now what's the third argument? So we've seen very clearly that in terms of who does what around the organizational control knob, the private sector alone is not necessarily going to benefit us, especially in South Africa. The government alone in providing healthcare is not necessarily going to benefit us in South Africa. We've seen that. So what's the alternative? The alternative is a third argument, a sort of quasi-public approach or model, where you're going to have a combination of what are some of the best practices from the private sector and the best practices almost from the public sector. So this sort of quasi-public forum or approach is saying, we can free ourselves of some of the restrictions that the public sector has. We could look at not necessarily sticking to civil service personnel and pay rules. Can we look at other different payment mechanisms? We can free ourselves of the government budget processes and look at a different way of generating revenue and collecting funds that will finance healthcare. We can try to be fiscally autonomous by setting your own prices and raising your own capital and keeping that revenue in your entities, in your service delivery organizations to actually improve performance. You can try and establish a external public purchasing system, right, to try and make sure that you can get maximize economies of scales and get the best price. And if you're looking at such quasi-public structures, these are typically governed by a board appointed by government but has diverse representation across all the different sectors in a country. So again, think about this from the perspective of the National Health Insurance Act. And think about it from whether or not South Africa then has moved to this point in time. Again, as I said, Tom is sharing his global experiences. But as I'm going through all of these points, I want you to think about it from the perspective of what is actually happening in South Africa today. And does this approach, this alternative quasi-public approach, help us realize or better understand what the National Health Insurance Act is trying to achieve in South Africa? of the other changes that we're looking at a macro level is thinking about how we would reorganize our existing health service delivery organizations, right? So decentralization is a mechanism that we could utilize to change how health organizations function. And we're trying to understand, this in terms of power, right? Instead of centralizing power and control, can we move this power and control down to lower levels? Okay. And in terms of decentralization, you're thinking about who then gets to have this control and power. How much choice do they get? And what mechanisms will we use to ensure that they're actually empowered to make the choices and the right choices? Now, I do have another module that's coming up later on in this year around decentralization. So if some of these concepts and points are confusing, don't worry, we will be discussing it further. Okay? But the whole idea around decentralization is thinking about what are the changes at macro level in terms of the organizational control knob that we need to change going forward to help improve the performance of your health system. Remember, each of the control knobs is trying to change the performance of your health system so that you can achieve your ultimate health objectives. So when we think about shifting some of the power and control to lower levels of your national system, there are two different types of decentralization. One is called deconcentration and one is called devolution. There are actually a few more, but we'll discuss that in the decentralization module. Now, under deconcentration, what you're actually doing is you're saying we have a central authority, and in this case, let's use the example of the provincial health department. The provincial health department is a central authority that holds the power and decision making for the whole province. But in deconcentration, you're moving some of the officials from the provincial office down closer to the community into your district and sub-district offices. So you've shifted personnel, but you may not necessarily have moved some of the decision-making power. So even though physically you've moved the personnel to your district and sub-district offices, some of the decision-making, the control over the decisions are still sitting at provincial level. So that is what is referred to as deconcentration. You're decanting or deconcentrating the central office, but you still are holding the power and control at the central office. So that's the one end, the milder end of decentralization in terms of who gets more choice. Then you go to the other end where there's greater choice, and that's called devolution. And here, the good example is if you look at the National Department of Health and you look at the Provincial Health Department. The National Department of Health doesn't necessarily take any decisions around operations of provincial health services. But the Provincial Health Department is a completely separate structure. It's autonomous from the Minister of Health. It can take its own independent decisions and it can actually make decisions. It has full control over how it runs provincial health services. So that's an example of devolution from national to province. Now, ideally going forward under the National Health Act, we're looking at a similar form of devolution between your provincial health office and your district health management offices, where you're not only moving the people physically down from provinces to district offices, but you're also giving the people in the district health management offices the power and the control over resources and decision making at that district level. So that's devolution. So there's a difference between deconcentration and devolution, okay, in terms of the type, who gets more choice. In deconcentration, there's still a much more centralized hold of power and decision making, while in devolution, there's a lot more control at a local level in terms of taking decisions and control over resources. And at hospital level as well, you want to make sure that you're trying to give hospital managers more autonomy. And that's important because you want to try and drive innovation. You want to make sure that if Hospitals are going to manage their budgets. They are not going to look at historical budgetary processes. They're going to start looking at what is it that they actually need in order to deliver their services. You want to ensure that there are modern management techniques that they can introduce, such as your lean management systems. And you also want to ensure that they also have some form of governance structures in terms of a board of directors and so on that oversees the performance of the hospital or supports the performance of the hospital. So developing hospital autonomy is also part of decentralizing and trying to check who actually gets choice and more choice to make. Now, you want to move power and decision making, but over what? You want to give choice to lower levels of government, but what choice, and choice over what? And how much choice are you going to give them? So the functions that you're thinking that could be decentralized to local levels are functions around financing, health service delivery, human resources, and even governance, as I mentioned before. And you need to think about how much choice you want to provide, how much decision-making power will they have for each of these choices. That's all inherent, again, in the decentralization process. And again, don't worry so much if these concepts are a bit confusing. We'll go into all of this in greater detail during the decentralization module. So in the decentralization module later on this year, we're going to talk about the different types of functions that you want to have choice over at your subnational level, such as your district health management offices. And you're also going to talk about the range of choice. How much choice do you think health districts or hospitals need to have around financing, around service delivery, around human resources? Should they, for example, be able to fire and hire human resources at a district or hospital level? Should districts and hospitals be able to decide salaries or how much they're going to pay human resources? Those are the sort of choices, and the range of choices that you need to think about need to be decentralized to those different levels of government. But as I said, we'll discuss this in greater detail in the decentralization module. But from the perspective of the organizational control knob, you need to think about all of these ways of tweaking and changing these mechanisms in your organization to get that system or that organization to perform better. So if you had greater control over human resources in a health district, would that make that health district perform better in order to achieve the ultimate health objectives for that community that the health district is servicing? So those are the considerations that you need to think about from the organizational control knob perspective. Now let's come to the micro level organizational changes that we need to think of from an organizational control knob perspective. So obviously you will have reforms that are being led ideally by your ministries of health, your national departments of health. And in South Africa, we know that the National Department of Health is leading the discussions and changes around the National Health Insurance Act. We're going to discuss some key changes that can improve organizational performance. We'll talk a little bit about the techniques around re-engineering government as well that can help improve your micro level organizational changes. So what are some of the keys to organizational performance? And there are 6 keys according to Tom Bossett. Firstly, you need to look at creating incentives for organizations to perform better. Secondly, incentives for managers to perform better. You also want to think about how to improve the attitudes, the values, the skills, and the beliefs of managers to perform better, strengthening the authority of managers, and thinking of incentives for workers to perform better, and how to improve workers' attitudes, values, skills, and beliefs. And again, you'll see a lot of this deals with leadership and management, which is again why it's so relevant for you as an ASALF fellow, because you need to think about what you are going to do differently as an executive leader in all of these areas. So some of the incentives that can help organizations perform better is to think about how they're going to be paid, right? Financial incentives are always a strong incentive. So can we look at different incentives away from your historical budgeting process and look at, prospective payments or generating revenues on their own, and whether your payments should follow the patient? So if organizations know that they will only get money according to the number of patients that they're going to see, they're going to start thinking differently in terms of their attitudes, in terms of the quality of care they're going to provide, and so on, because they're not going to get money unless the patient comes to them. So that may change the performance of that organization. So payment incentives can change an organization's performance. Managers, how can we incentivize managers? We may want to move away from your promotion that's based on longevity, right? Your gray hair, the older you get, the more you could move up in the organization. But rather you want to maybe look at recruiting or promoting managers based on their skills, on their attitudes, and then their values and their knowledge and their contribution towards improving the performance of the health system, as opposed to patronage and political affiliation, right? And you also want managers who are willing to try things and be innovative and are willing to fail as they try those different things and are interested in solving problems. You don't want managers who are afraid of making changes, okay? So again, you want to create an environment where the organization supports and incentivizes such managers. And for many of us here sitting here today, I'm sure we don't identify with this situation because we are working in organizations that make us afraid to try new things. We are working in organizations that are looking for people to blame rather than for encouraging people to find solutions for the problems that we are in. But if we can create an environment where managers do feel safe and do feel appreciated and recognized, we may change their approach in terms of how they're performing. The authority of managers. I spoke earlier about the type of control managers should have, whether it's at a district health management office level or whether it's at a hospital level. Should they have the authority to hire and promote and fire and give incentives to workers? And if they do, will that change the way those workers perform? Right? And will their decisions, if they have that authority, will those decisions be backed up by their superiors? So again, that's going to be an important way that you need to think about how that organization is going to be reconfigured or re-engineered to improve this particular function or choice that you want managers to have. In the South African context, we know that we have very strong unions. What will be the role of unions then in this particular perspective? Currently now many managers are hampered. They don't even, we talk about consequence management, and we know that managers are hardly taking consequences on employees that are not performing well or not doing their activities well. But now if we were to change how that organization functions, by looking at how payments are made to that organization, that it's going to depend on that employee performing well, that employer having a good attitude and a good value system, then maybe things can make this, maybe managers will have better support in terms of enforcing this authority, right? And maybe the unions will understand this better, because unions don't want their workers to lose work. The unions need workers, right? The unions cannot exist without workers, and if there are no workers, then unions can't exist. So there could potentially be an opportunity here to see how managers' authority could be improved through decentralization as a mechanism to change within the organizational control knob. The same, if we look at incentives for workers, for health workers, again, we can look at how are they paid. Are they being paid salaries? Are they being paid salaries and bonuses? Are they being paid fee for service? Do they have merit-based performance reviews? Do managers use the performance reviews to actually provide bonuses? And again, all of us have our own examples and our own experiences within our own context in terms of our performance-based management systems. We know that If people are just paid a salary, there's no incentive per se to improve quality and the type of service they're providing. If people are paid according to fee for service, there's also no incentive to improve quality because they can just over service. So again, you need to think about how you're going to develop the payment mechanism. Again, it's a financial incentives for workers to see how they can improve within the organizational control knob. Okay, even though it relates to your financial and payment control knob, the structure of how you're going to bring in these incentives within the organization is the change that has to happen within the organizational control knob. Workers' skills, attitudes, and values. Are they being recruited based on their skills or attitudes or patronage and political affiliation? And again, do they fear making changes, or are they interested in problem solving? So again, it's about creating that enabling organizational culture that everyone feels valued and appreciated and can contribute and wants to contribute and is willing to try things to make a difference in their organization. Now, how can you re-engineer government, by bringing in some techniques maybe from the private sector? What are some of the best practices that we can bring into the public health sector? So we can look at, incentives firstly on provider facilities, looking at pay for performance, which was covered in the payment control knob. We can look at prospective payments. We can look at revenue generation at facility level. So if, for example, you are generating revenue from various resources, maybe the road accident fund or compensation fund, could you keep those surplus or those fees in your facility to incentivize your health workers, to upgrade your facilities? Right now, we know that national treasury regulations prohibit us from retaining any revenue that's generated at facility level. So can you change that? Can we change that within the organizational control knobs that facilities can actually retain some of these surpluses? How do we introduce competition between providers without destroying the effects of collaboration and teamwork, right? You still want to have healthy competition from the perspective of looking at developing innovations and good quality care, but you don't want to destroy collaboration and teamwork, right? So again, you need to have a fine balance between competition and collaboration and teamwork. You want to give managers more authority and decision space. That's the decentralization approach. You also want to give them incentives and greater accountability mechanisms to improve performances, right? We hear about it all the time in the private sector where CEOs are paid these massive amounts for as performance bonuses because they were able to achieve what they said they would achieve in terms or exceed the expectation in terms of what their board had asked them to do. So similarly, in the public health sector, could we create those incentives for better performance? So that's part of re-engineering how governments function so that governments can then play the role that they're intended to play around healthcare service provision. Management contracting is another mechanism that we can utilize for incentives and supervision. Again, contracting will be covered a little bit in the payment control knob, but you need to think about what are some of the performance indicators and measures that you would need to include in your contracts. How can you negotiate? Can you develop negotiating skills between the subordinate and the supervisor? And what are some of the rewards and sanctions that you would have that you could include in your contracting? Right? So, for example, if you were able to achieve certain performance, then you would get a reward, but if you were not, would that reduce your budget, and so on? Again, what would be the impact of that in terms of payments of your health workers in that organization, and how would that also impact on poor performance of health workers, right, that are not performing well, and whether it will give you the ability to make those decisions if you were to include that, all of those measures in your contracts with your service providers. Certainly, incentives for public workers is to try and create a much more transparent merit-based system of hiring and firing and promotions in the civil service. You want to try and look at replacing seniority with achievement. And we saw that to some extent in the, for example, if you look at the occupational specific dispensation. So previously, if you wanted to move up in the let me use the example of medical specialist because that's something that I'm more familiar with. If you wanted to be a head of department or a chief specialist, it was actually based on the number of years that you had in the system and your experience. It was literally your gray hair. But now under the OSD, they've actually said, as long as you have a certain minimum years of experience, you could still apply. You could be a junior person. You could just have 3 years of experience as a medical specialist in order for you to apply for the head of department or head clinical unit position. What they're looking for is not necessarily seniority, but what they're looking for is achievements. Are you able to contribute and be a good manager and leader in that position? So that's a good way, I think, that the OSD tried to address this particular incentive, right? You need to have a transparent system with committees, so that people understand why you're employing certain people or certain critical skills or certain cadres of employees and how you're actually doing that process. You could use contracts again to get around civil service restrictions. We said that the civil service rules and regulations may be too restrictive to improve performance. And because you're trying to tweak the organizational control knob, you may want to look at using contracts to get around civil service restrictions. I don't know how far that's going to fly in the South African context because everybody is pushing to go towards your public service act and your public service rules and regulations, because there's a lot of job security within the public service. Obviously, with contracts and greater decision making around hiring and firing at a local level, you are destabilizing or thinking of destabilizing their job security. So how well that's going to be received by unions and health workers in South Africa is not very clear. But these are how other countries have managed to get around the restrictions around civil service rules, and they've used contracts to help better improve the performance of public health workers. And again, I'm just putting it out there for you in the class to think about, what does this mean for South Africa? You could look at bonuses for individuals and teams, and again, we've got some country examples there. We do use a lot of symbolic rewards. We say, oh, best employee of the month, or the employee who's always got a great attitude. But those symbolic rewards are great and they should be in place. I'm not saying they should not, but sometimes you need other incentives such as financial incentives and more contractual incentives to get health workers to perform better, right? So think about that. Now, if you're looking to change attitudes, values, and skills, you need to make sure that you're choosing and recruiting the right type of staff. You want staff with the right skills, right? And the right attitudes and so on. So your recruitment processes, your selection processes has to be much more robust and more technical, rather than at this moment very much based on an understanding at a local level of what needs to happen. We're just looking right now at qualifications and maybe professional registrations, but we're not necessarily thinking about attitudes and values when we're recruiting staff. We're only looking at whether they potentially have the skills, and the only way we can determine that is if they have a professional qualification or documentation that supports that. But we need to maybe move towards improving our recruitment systems to really address things around attitudes and values. So recently, my daughter moved overseas to one of the Scandinavian countries. That's where her husband is living, and that's where she has now moved. And she was applying for work, and she was telling me about their whole recruitment process. And she's a professional. She's not a health professional. She's an engineer, and so it's a technical professional qualification. But when you look at their whole recruitment process, they've got so many different layers and levels of interviews. So firstly, there's a process of checking whether you have the right skills. But then the subsequent interview processes, that's 2 or 3 or 4 or 5 or even 6 rounds of interviews. It's more about teasing out the attitudes and the values of this individual that this organization is seeking to employ. They want to make sure that you fit in with their organizational values, right? Now, I think in the health sector in South Africa, we don't go follow that process. We just go with the first process, which is, do you have the skills that we think you will need? And this is based on your qualifications and the documents you supply to us, and that's it. We don't necessarily think about whether the person has the right attitudes and values that will fit into our organizational culture. So we may want to think about that process as well as a mechanism within our organizational control knob to help us get people that can change the performance of our health system. You obviously want to build capacity too. So much as you're trying to develop managers and health workers who need the reason to change, who need a reason to change, and you're providing that reason to change because you're saying, that reason to change could be incentives, it could be contracts, it could be understanding from your attitudes and values. You also want to build the capacity of these managers and health workers to effect change. So you want to think about training managers and health workers for these new skills, right? So again, I'm not necessarily going into the details of that, but I'm sure you understand that point. The organizational culture. Again, part of the organizational control knob is saying, can we tweak that control knob to improve the organizational culture? And one of the fundamental changes you want in an organization is you want to build a learning organization. You want to build a culture of learning within that organization. Because if you have a culture of learning within an organization, you are going to find managers and health workers who want to make a difference, who want to innovate, who want to try, and who know that as they try, they may fail. As they try, they may make a mistake. But in that process, they are then also learning about what is working and what is not working, right? And a lot of that is dependent on the attitudes and values of the managers and the health workers that you've recruited, because they want to make a difference and they want to take responsibility. They want to collaborate. They want to solve problems. And changing culture in an organization takes a long time, right? And it has to have the support from the top. But you start by slowly building that in, by slowly recruiting people that you know will have the attitudes and values and skills that resonate with your organizational culture. You also want to make sure that there's this culture within the organization of really improving quality, right? And so you want to empower your frontline workers to solve problems, to identify issues quickly and early on, and you want to give them simple tools to be able to determine all of this. So changing your organizational culture needs to start, and it needs to start today, right? And so that's another important part of tweaking your organizational control knob. So what are some of the tools that we could use in terms of re-engineering government in addition to what we've just shared? Private organizations talk a lot about mission statements and strategic planning and leadership skills. And I think in South Africa, over the last 5-10 years, we've moved a lot towards this. Many of our health organizations, especially in the public health sector, we do have mission statements. We do a lot of strategic planning, and we're trying to develop leadership skills. But these are techniques that help us re-engineer our government. So your mission statements are really important because they help define where you see this organization going, right? An example is, you look at the World Bank. When you think of a bank, you're thinking of a bank. It's a financial institution. But look at the mission of the World Bank. At this point in time, it was poverty reduction. And yet you don't associate poverty reduction with a financial institution. But the World Bank's goal is not about building a lot of money. It's about really empowering countries and empowering countries through financial mechanisms so that they can over time reduce poverty in their countries. That was their long-term vision and goal. And so that's why they put that as their mission statement. So what then would be an appropriate mission statement for ministries of health? We need to think about it from the perspective of not necessarily just your core function, but also thinking about what is it that you really want to change going forward. Obviously, for countries right now, we have all the concepts around universal health coverage and the ultimate health objectives. But thinking of a really great mission statement that's short and sweet and really summarizes and crystallizes what you're trying to achieve can make a big difference in terms of getting the buy-in of everyone within your organization, right? Strategic planning, I think we've spent a lot of time discussing this during Prof Book's strategic thinking module, but you want to move away from your traditional health planning exercises where you're just looking at what happens every year, and every year you're just looking at the number of visits and so on, but you want to think more long term. What is going to happen, what's going to change in the next 5 to 10 years, and what activities do we need to start now that are going to help us reach our longer term goals, and really look at those competitive edges, the innovative edges, and really consider our organizations much better, understand our organizations much better in terms of where we're trying to get to, right? So strategic planning can be a very effective tool as part of the organizational control knob, as part of changing the organizational control knob to improve the performance of our health system. Leadership, and I think, again, without leadership, we know everything that we're doing and everything that I've been saying today, and in all the modules that you've been exposed to, we cannot say it enough that leadership is the fundamental golden thread through everything, right? And as managers, as executive leaders in the health system, this is your big opportunity to really try and create those changes that are required within the organizational control knob, both at a macro level, as I've said, as well as at a micro level, to really change and improve the performance of your health organization. You obviously need to think about upgrading your systems. You can't just only think about management and leadership. You need to look at systems that can support and complement anything that you're doing. Information systems, logistics systems, supervisory systems, all of those are also part of your organizational control knob, right? And those must be tweaked and improved to get your health system to perform better. So when you're looking at transforming your organizational capacities, you want to also look at other key skills that may be required for your organizational to change, right? You need to look at financial analysts, you need to look at human resource managers. I spoke about having better recruitment practices. Do our current human resource managers have those skills? Are they really the top in their field in terms of understanding best human resource recruitment practices? And I would say no. I don't think any of our provinces right now have top-notch human resource managers. But we may want to look at that. We may want to look at what's happening in the private sector and internationally and see how we can align ourselves to that. Do we have sufficient specialists in specific technical skills like ICT and digital technology and so on? And if we don't necessarily have the labor pool for these skills, I think we do have the labor pool in South Africa for these skills, but what we may not have is the ability to afford that. But then we can look at additional resources from other local sources, such as local universities, consulting firms. We can look at technical assistance from international organizations. So we need to think about how do you bring in these additional resources and skills to help us transform our organizational capabilities, right? And all of these then have become important mechanisms for helping us tweak that organizational control knob. So the key lessons for the micro level organizational change, think about what are some of the techniques from the private sector that we can bring into the public sector. We do have a lot more obstacles as public sectors to overcome, and so we need to think about how we're going to overcome them. We need to work on improving incentives and organizational culture. We need to build good systems, and we really, I can't emphasize this enough, we really need to become really good leaders. So these then are all the critical lessons for the micro level organizational change. So I hope from all the discussions that we've had in the last few slides that you've got an understanding of what are the changes that we hope to achieve through the organizational control knob. At a macro level, you really want to think about who does what, and I hope we've made the argument for why the private sector alone can't provide healthcare services in South Africa, why government alone can't do that as well, and with that we need a quasi-public sort of structure where we involve both the public and the private sectors to provide healthcare. And we need to think about how we're going to reorganize our health health services in terms of looking at decentralization as a mechanism. We also need to think about how we're going to create incentives for these different sets of actors, whether it's the public sector, the private sector, the national, the provincial, and the district level organizations to interact with each other and improve their performance. And at a micro level, we need to think about really how do we change the approaches of managers and health workers, how do we incentivize them to improve the performance of the health system that they're functioning in. So all of these then provide the mechanisms to change the organizational control knob. Thank you very much.